Bismillah, walhamdulillah, wassalatu wassalamu ala rasulillah, amma ba'd. Assalamu alaikum wa rahmatullahi wa barakatuh. Welcome to another episode of Send in the Community with me, Hafiz Muhammad Umar. And in today's show, we are going to be talking about health equalities and what it means and what is the offer out there um, from the local authority as well as from NHS England. We are going to be predominantly focusing on this offer in and around Luton, but we will try and cover the wider Bedfordshire, which includes central Bedfordshire, Bedford itself, and surrounding towns and villages. And with me to discuss this today, I am delighted to be joined by Simone Mingay, who is the clinical nurse manager. Welcome to the show, Simone.
Thank you. Thanks for having us.
Thank you for coming in. Also, Karen Ferguson. Karen is the health facilitation nurse specialist. Welcome to the show, Karen.
Hi. Thank you for having me.
Thank you so much for coming. Just to remind our listeners that this is a show dedicated to promoting awareness and raising profile of special education needs and disabilities, including medical conditions. And we try to have different speakers, guests each week during the term time. And that includes people with lived experiences as well as professionals involved in supporting those individuals and policymakers, including local councillors and higher up the chain around the political world as well. So our commitment is to ensure SEN remains high on the agenda. It does not get forgotten, and which is why we have these amazing people with us today as well. So ladies, tell us a bit about yourself then, please. So Simone, about you and your role, please, if I start with you first.
Yeah, thank you. So I'm Simone. As you said, I am clinical nurse manager, but also the specialist healthcare team manager for services for people who have a learning disability. I'm a general nurse by background, but kind of after various different career roles, have moved into working in this fantastic service, supporting people who have a learning disability. I really, really love it. Been a nurse for about 27 years and can't imagine doing anything else.
Brilliant. Thank you so much. And Karen, a bit about yourself, please, about your background and your role.
Hi, yeah. So I've probably, similar to Simone, probably not quite as many years, but I'm a learning disability nurse by background, and I've worked for about 25 years in that role in various situations. But I think I've worked within the health facilitation service now coming up for 14 years. So I'm really passionate about equal access to our primary healthcare, looking at sort of focusing really on physical health and making sure that the access is there when people need it, so that they can have the best possible health outcomes.
Brilliant. And just for the benefit of our listeners, when they hear the word somebody is a nurse and somebody is a learning disability specialist nurse, what difference could they expect from those amazing in different roles, please?
It's really interesting because Simone says she's a general nurse by background, so she would have had slightly different training than I would as a learning disability nurse. And I suppose the differences are that we specialise in learning disabilities and what that means. So from an SEN perspective, looking at those physical health conditions, cognition, brain function, looking at how that person communicates, so much more of a holistic approach than maybe the more medical model within general nursing. That's to say that actually nowadays the training tries to encompass all aspects of that. But I think from a learning disability and SEN perspective, it's much more of a holistic outlook. So we're not looking at one particular thing. So they're coming in and they've got heart condition. We're looking at the person as a whole, looking at how they communicate, what their needs are. And I think that really helps us work really well with families and other members of team, as well as staff teams and carers. So I think it's much more of an individualistic approach.
Brilliant. Simone, so for anybody who has a learning need and ends up either at the doctor surgery or hospital and seen by someone like yourself, Simone, who might not necessarily have the specialist learning disability nurse title, what could they expect the nurse to be able to do for them?
I think, that's part of the reason why our team is in place, that we acknowledge not everybody's maybe got the skills or the knowledge to be able to support someone with a learning disability. So a huge part of our roles is, I suppose, educating people, giving them the knowledge to be able to support someone in a health-related situation who's got a learning disability. And I think, yeah, as we said a little while ago, I am a general nurse, and I think just to touch on something that Karen said, I think that the difference between the roles is learning disability nurse. It's more than just about healthcare. It is holistic. It's about championing the people that we're trying to support, making sure that they're treated fairly, they're treated with dignity and respect, and they're included in everyday society, because we'll probably come on to talk about it, but health inequalities are when people are facing those barriers in health and everyday life, and that's part of the reason why the learning disability nurse role is so vitally important in primary care, so with GPs, but in hospital situations as well. So I think, yeah, we do a lot of training, and a big part of the role is equipping other healthcare professionals with the skills and knowledge to be able to support people who have got a learning disability.
And I guess would it then perhaps be fair if I was to make a comparison for our listeners out there with education, the fact that if a child is in a mainstream school, whether primary or secondary, and they have an added need, they might not necessarily have specialist teachers, say, that might work in a special school, but the expectation is that all teachers and staff that come across them will have certain element of SEN training as part of their general qualification to be able to meet their need in a mainstream environment. So if parents are thinking, my child goes to mainstream school and they have, I don't know, either an education healthcare plan, or they have added diagnosis of a particular condition for which they are being supported in a mainstream setting. In schools, we take SEN as everybody's responsibility, not just the Senkos or not just the specialist schools, but in every school we try to meet the needs. So if you were used to try and use the analogy perhaps for parents to reassure them that once you're accessing health services, rest assured that the nurses that are seeing to your child do have a general understanding and training around SEN. And then for somebody like with Karen, there is an added qualification they have gone through, which gives them the specialist disability nurse title. Would that be a fair comparison?
I think, yeah, you're exactly right. It's every nurse's responsibility to be able to meet the needs of any patient that they need to support. As you say, Karen's got a specialist learning disability nurse qualification, but that doesn't mean that, general nurses like myself in a hospital situation shouldn't be able to meet people's needs. And that's part of the reason why we invest so much time into training. And there's also now nationally, there's a mandatory sort of learning disability and autism qualification that all healthcare professionals are expected to take. That's called the Oliver McGowan training. So it's, nationally and within government, it's been recognised that that's a key amount of knowledge that every healthcare professional should have, which is good. It's a big step forward from how we were maybe 10, 15 years ago.
Brilliant. And if with my education background, I will probably make a few comparisons. And it's like an education, every education institute, there are nursery, primary school, secondary, even colleges, by law must have a Senko in position, and that is somebody who has a special education needs and disabilities coordination qualification or is working towards it. That is a legal requirement, and so yeah, it's really good to know that in the NHS, similar, if not greater, work is being done to ensure those health inequalities are being reduced and people being able to access the services. Let's talk a little bit more about the East London NHS Foundation Trust then. So the name would perhaps suggest this is around London. How does that then cover our neck of the woods then?
Do you want to go, Karen?
So it's really about contracts. So East London, yes, primarily they also have services and provision within the London area, but I suppose it's been a long time. I'd say about 12, 13 years now that they've had the contract for Luton and Bedfordshire, both with mental health services. They're primarily a mental health trust, and then they've got they had the contracts then to take over the specialist learning disability services. So our base is at Twinwoods in Bedford, but we cover Bedford, Central Bedfordshire and Luton. So that's our sort of county-wide patch. And they also do have learning disability services within London as well. So I suppose from a trust perspective, we really work towards those trust goals of, that inclusion, as Simone said, inclusion, equality for everybody, and I suppose they then would keep an eye on what we're doing and making sure that we're doing everything correctly. So for us, it's business as usual, and we work underneath the trust, the East London Foundation, ELFT. And I think within that, then ELFT answer to the ICB, which is BLMK. So that's where we work alongside BLMK quite a bit, especially around the learning disability services and the annual health checks that people are entitled to if they're on the learning disability register. So the annual health checks are 14 plus. So Simone and I and the team do try and promote that. Although we are an adult service from 18 plus, we try and work really closely with any transitions and sort of children's teams. So transitions have got an idea of what to expect or what might be available within adult services. But the annual health check itself is actually an NHA initiative that's been going for a few years, well, many years now. But I'd say in the last 5-6 years, there's been a real push to increase the numbers and the quality of the annual health checks. And they can be offered and should be being offered at the age of 14 plus. And that's something we're always trying to promote, because people aren't always aware that they're entitled to that annual health check at 14 plus.
Mm-hmm. And who would facilitate those annual health checks? Would that be through the GP? Would that be on a line of the parents or carers or the patient?
So it doesn't have to be a GP who carries them out. I mean, it could be a range of staff within the GP practice, but they will be led by primary care. So the GP practice could be a GP that does them, or it could be a nurse or a paramedic. But I think, as Karen said, it's really important that a lot of parents often aren't aware that an annual health check is a thing. They aren't aware that if their young person is on the learning disability register, that they're actually entitled to such a health check. And, we're really keen to advocate that they are very important, because, a lot of people think you just will go to the GP if you're unwell, but an annual health check is a bit like taking your car to the garage on a regular basis. It helps you it helps your body keep ticking over. It will pick up on if there's any potential disease processes that might happen in the future. Just, it's a really good thing to have. It's free, and people who are on the learning disability register are entitled to it. So I think if there's one key message that people take away from this session, is that, if your young person has reached the age of 14 and they haven't had an annual health check, then go and speak to your doctor about it.
Brilliant. Listeners, if you've just joined in, you're listening to Send in the Community Show with me, Hafiz Muhammad Umar. And in today's show, we are discussing health equalities, and my guests are Simone Mingay, who is the clinical nurse manager, and also Karen Ferguson, who is the health facilitation nurse specialist. And we are talking about the offer for Luton, Central Bedfordshire, Milton Keynes in particular, but also in its broader sense. So if you are tuned in from around the country, a lot of this advice is generic. You can access the services in a similar way to what Simone was just talking about. Things like annual healthcare are available, annual health checks rather, are available for all people with disabilities above the age of 14 around the country. And you just need to make sure you contact your local service providers to be able to do that. So let's just talk a little bit more about the health equalities and why there was a need to have this additional service offered to our communities. What kind of barriers exist which make people with disabilities perhaps which make it difficult for them to be able to access services as regularly as, say, perhaps people without disabilities? Karen?
Yep, I'll go with that one. So trying to unpick that because there's a lot there you've asked. So health equalities or health inequalities is quite a huge topic, and I'm quite passionate to talk about that because there shouldn't be, and we all know in reality is different to what should and shouldn't be. But I suppose that the nutshell is equity. So it's about making sure that individuals' needs.
So, Karen, I lost you.
So that they can access whatever it is they need to access. Oh, sorry. Can you hear me now?
Yes, I can hear you now. So I lost you for about 10 seconds.
Yeah, you can hear me now. Sorry. So it's about equity across the board. So it's not about making one thing, making one access point. It's about looking at individual needs and how that person needs some adjustments or reasonable adjustments, which is mentioned in the Equality Act, to access support when they need it. As Simone said, that's if we're unwell or we need to access the GP, then we would follow the process we need to, which is either an online form these days or a telephone call. If we're working with somebody who has a learning disability, they're not able to necessarily do that. So it's about looking at how can that person access that support? What support do they have around them? Because sometimes there is an assumption that there's a carer in place or that they have a staff team around them or they have lots of family members that can do that. And a lot of the time that is the truth. But equally, there are people that live quite independently that need support to access. So it's about looking at the individual need as opposed to saying, well, we have a ramp out the front, so that means everybody can access our building. It's about looking a bit deeper than the peripheral, really. And I think there is so many gaps in provision. And I think we're seeing it more and more actually now, as Simone would probably agree, because there's so many financial issues across the NHS now. So it's really about us working harder to push those reasonable adjustments. So if somebody needs a home visit because you're just not going to be able to get them to the GP surgery, then that's what's needed. A telephone call is great for some people, but actually sometimes somebody needs to be physically seen. And it's really tricky, but it's about individual need. And I think that's where we're quite passionate about people making adjustments within their services to meet that need. And that is
absolutely difficult. Yeah. Thank you so much for that, Karen. I was just going to come in there to bring it to our listeners' attention the Danny Review, the publication that was published a couple of years ago. And it's, in its executive summary, it actually fully pretty much backs what, Karen, you were talking about there. So the socioeconomic factors, including low income and low educational attainment, that's about 40% of the driving factors for health inequalities. the physical environment, poor housing, poor air quality, and a lack of green spaces, another 10%. Health behaviors, for example, smoking, drinking, excess alcohol, not taking enough exercise or eating a healthy diet, and then health care if a person is not accessing health services or if they do not meet their needs. And then on top of that, for diverse towns like Luton and Bedford, these factors often combine to mean that a person facing health inequality is more likely to be in poor health. And then the groups they talk about, I mean, people living in deprived areas, people from ethnic minorities, and the traveling community, people with physical or learning disabilities, and those experiencing homelessness. So absolutely, what you're saying, Karen, is spot on with the findings of this Danny review, which I think was published around 2023. So this is still quite recent, quite relevant, and I guess more the need for us to be able to try and address these challenges and tackle those barriers. Sorry, Karen, I just wanted to bring that a bit of research in there for our listeners. The fact that Karen is talking here, it's not just the case of let's address Luton or Bedford or Milton Keynes or St Bedfordshire. Actually, there's a lot of research behind what Karen is talking about. Please, I'll let you finish off what you're saying.
No, I think you're right. The Denny review really leads into these health discrepancies, I suppose, in accessing support, and I think some of it is awareness. And if we're not aware of something, how can we access it? If we don't know what we're entitled to, will we ask? And I think within the learning disability services, we very often look at what's called the LEADAR, which is the learning from lives and deaths of people with a learning disability. And that basically anybody who has a learning disability, when they die, they look at the LEADAR review, looks at the causes of death and the reasoning, not to hold judgment. It's not coroner's court, but it's about looking at learning and how can we make things different. And despite, the numbers are still there of people with a learning disability are dying on death. They're dying when it could be avoided. And I think that for Simone and I and the team is one of those things that really pushes us to sort of say, nobody in this day and age should be dying of constipation. Nobody in this day and age should be dying of things that we can avoid if the right investigations and treatment are done at the right time. So we always sort of say, that it's the right time, it's the right space, and it's got to be meaningful for that individual. So yes, the Denny report is really, really crucial, I think, in what we're saying as well.
And then, Simone, from a clinical nurse perspective, what does this mean for the wider community then?
I think for us as a team, it's all about, I always think people who have a learning disability generally have a significant amount of barriers that they face on a day-to-day basis. And particularly if you're from a diverse or underrepresented group, you've got more barriers. So for us, it's all about trying to work with people to reduce those barriers. Health equalities is, I think for me, it's just making sure that it doesn't matter who you are, what your background, what your culture or your disability is. Everyone deserves a chance to be healthy and happy. And I think if for us, that's about tailoring our support, not using that blanket one-size-fits-all approach, so we can give that holistic amount of care and input to people. There are other groups within society who equally have a lot of barriers against them, but as Karen's touched on, sort of leader report, physically and socio-economically, we know that people with a learning disability and the carers, they have a lot of barriers. So we're all about working to break down those barriers, make sure people are treated equitably, and things are fair for them. In terms of the health side of things, as a team, we do a lot of health promotion, health prevention work, and we're trying to work more one-on-one with more lesser heard community groups as well. to enable them, to highlight the importance of annual health checks. Things like cancer screening programs as well. We know that there are lower uptake on cancer screening in sort of those diverse community groups. So we want to be working with people to, again, just to highlight the importance of going for health checks, working with them to understand why they're not going, what can we do in terms of reasonable adjustments to support and encourage them to go for these additional health checks that will keep them fit and well.
Brilliant. Thanks so much, Karen and Simone. Listeners, we are fast approaching a short break now. And when we come back after the break, we will carry on with this conversation from here. So we will be looking at the recommendations from the Danny Review, as well as what else is available out there in trying to reduce the gaps in accessing health equalities. So please do come back very, very shortly. Wassalamu alaikum wa rahmatullahi wa barakatuh. Bismillah walhamdulillah wassalatu wassalamu ala rasulillah amma ba'd. Assalamu alaikum wa rahmatullahi wa barakatuh. Welcome back to the second half of today's Sending the Community show with me, Hafiz Muhammad Umar. And if you were with us before the break, you will know that in today's show, we are talking about health equalities or health inequalities. And I am delighted to be joined by Simone Mingay. Simone is the clinical nurse manager. Welcome back to the show again, Simone.
Thank you.
And also, I'm joined by Karen Ferguson. Karen is the health facilitation nurse specialist. Welcome back, Karen.
Hiya, thank you.
Thank you so much for joining me back. So if you were listening before the break, you will know that we were talking about a number of factors that could be considered to be contributing towards health inequalities. One of those is around special education needs and disabilities, which is why we put this in the show on each week to ensure the SEN element isn't forgotten. And we continue to raise profile of various special education needs and disabilities and conditions. And today we're looking at health inequalities, particularly for people with SEN. But alongside that, we do take research very seriously, and we discussed part of the Denny Review, which came out in 2023, addressing challenges in and around Luton and surrounding areas, including Bedford, and what those issues are and what the review's own recommendations are in tackling those issues. So during the second half of the show, we are going to be talking a bit more about bridging those gaps. And to that effect, I'll start right from the very first element where the review came up with a conclusion that following an in-depth engagement work with residents from all these diverse groups and beyond, 4 teams had emerged, and the first one was around cultural competency, second around communication, third around access, and fourth around representation. So if I start with you, Karen, and ask about communication. So somebody who might have difficulty in communicating either verbally or because of their sight or hearing, what can they expect when they are trying to access the services, please?
I think that is one of the biggest barriers, I think, is communication and understanding that goes alongside that communication. And I think Simone will agree, within the NHS, we like to use long words when we don't need to, and we like to use 10 words when 2 will do. So it can be very confusing for anybody not with a medical background necessarily. I find it confusing myself. So anybody that maybe has any communication needs, whether that be a language barrier, whether that be an understanding of how to access services, the pathways that are being used, or whether that is because they, certainly within learning disabilities, somebody may not have that understanding of what some of the words mean. So if you're using language that is not clear and simple, you lose people in translation, regardless of the language being spoken, if you're using the wrong words. So I think certainly within learning disabilities, communication is one of our fundamental barriers, because we have an awful lot of people who have very limited verbal communication, or who are non-verbal. So actually you've got to look at body language, and you've got to look at pictorial symbols, and you need to look at different communication methods so that that person is included in their healthcare journey, whether that be within a crisis or whether that's when they're well and they're having their annual health check. And we do have a lot of carers, whether they be parent carers or paid carers, say still that professionals will speak to them rather than the person who has a learning disability. And I think that I can understand it from a certain point of view if they're gathering information and that individual can't give it, but it's about including them in the conversations and allowing them time to process information being given to them and allowing them time to answer. And time is a commodity that we hold very dearly and we don't like to waste. And I think actually what we have to sometimes do with communication is look at having additional time so that it is very clear when people leave, whether it be the GP surgery, whether it be the hospitals, whether it be anywhere, where they leave that appointment, they have a real good understanding of what's going to happen next. And I think that's what's very often missing. And that gets lost in translation, whether it by a language, or lost in communication translation where wrong words are being used. And people will often say, we all do it. People will often say, yeah, okay, I understand that. And you walk out the door and you think, I haven't got a clue what I've just agreed to, or I haven't got a clue what's going to happen next. And then that we often as nurses will go in and have those conversations with parent carers or staff carers, and they're not always clear on what the next steps are. And I think that can cause then quite a lot of anxiety. And so communication is a real issue. And I think language, certainly, that cultural competency / language barrier that very often we have within Luton and Bedfordshire adds to that confusion.
Absolutely. Thank you so much for that, Karen. And I guess there's then the additional challenge for people experiencing homelessness, for example. Letters could be sent when they cannot receive them at all. And people who are hard of hearing, perhaps, knowing the fact that hearing loops are not being made available for that person when they are seeing a health specialist. So again, that communication between the individual patient and the health service they're trying to access has to be really, really crucial. Simone, when it comes to cultural competency, what can people expect when they are trying to access services?
I think historically there's been an issue because services don't always understand or respect people's backgrounds, beliefs, sort of cultural needs that they have. So I think there is a huge need for training for staff, in cultural awareness, unconscious bias. We need to have a better understanding of people's beliefs so we can tailor and meet their needs, their health related needs in a way that's based on that person's personal preference. Karen previously referred to reasonable adjustments, and again, sort of, if we're there's take-home points from people listening in. I think it's really important that people understand that under the Equality Act, reasonable adjustments are kind of law. They're things that all healthcare professionals should be offering to people. So it kind of links in with communication as well, but offering those reasonable professionals, making those reasonable adjustments, giving longer appointments to enhance people's ability to understand, offering same-sex clinicians, if that's somebody's personal preference, we shouldn't be saying no. We should be respectful and mindful of cultural beliefs. And if that's what somebody wants, or they want a chaperone in with them for an appointment, all of that should be happening. And ultimately, we have to recognise that different communities have different health beliefs, and we should try and meet people in a way that meets their needs and those health beliefs as well. Again, it goes back to health isn't a one size fits all. We have to make it individual, and we have to be respectful that people won't always have the same belief system as us. That doesn't mean it's wrong. We need to be working towards catering and meeting their needs in a way that works for them. So I think for me, that's kind of what that cultural competency is. It's understanding people and where they're coming from and working towards us, but not only us, the wider health system, in meeting their needs in a way that they want.
And thank you so much for that. And on that note, I was talking to somebody recently, a local female resident in Luton, who had booked for an ultrasound and had made it very clear that she wanted this to be carried out by female members of staff. So her appointment was put back from the initial date she was given to ensure that the female members of staff were going to be available to conduct this ultrasound. And when she went for the appointment, she was called in, and there was a male member of staff present to do the ultrasound herself. And she felt quite uncomfortable, but had the courage to tell them that actually I had requested a female member of staff for this. And she was told, actually, no, that cannot happen. You need to go back to your GP. Another referral needs to come. That will take months. So it's either here or you can't do this. And luckily for her, in the neighboring room, the conversation was overheard because the member of staff there was available, and she was free at that time, constantly about to take the next patient, and her next patient was a male. So she came out and said, actually, you know what? This is straightforward, so we can do this right now. And she apologized to the patient, the female patient, said, I'm really sorry, there must have been, some kind of a lack of communication. When we got the referral, we did not see specifically for a female member of staff. Had that not happened, this patient could have then been faced with either being seen by somebody she felt very uncomfortable with, or had to wait another up to 2-3 months before she was going to have a scan again. And I think it's those kind of reasonable adjustments, perhaps, that both of you were talking about. Where there's a will, there's a way. And in this instance, it sounded like that they were, a very competent, culturally aware members of staff who actually straightforward. So a male member of staff on the other side, we send a male patient there, we call the female patient in here. So sometimes this a small change like that can make a significant difference to the patient. And we want all communities to feel comfortable and having the courage to be able to not only request what they need, but equally be prepared to remind staff as well if things haven't turned out the way they were expecting. Because we know, once you ask for something, it goes through so many loops before it reaches the individual that's dealing with it. And if it's something that's lost in communication, it's important to remind them as well.
Absolutely. I think it's great that she had the courage to sort of speak up and say that. And I think for us, we know that someone with a learning disability, if they're unsupported at appointments, they may not be able to do that. So it's really important that somewhere in the medical system, that those reasonable adjustments and those preferences are documented. And I guess now's maybe a good sort of time to talk about a document that we have. It's called My Health and Me. And it's kind of it's a document that is taken to a lot of hospital appointments, health-related appointments, and it tells healthcare professionals what somebody's preferences are, what reasonable adjustments they may need for appointments to improve that healthcare experience for somebody. So we would always advocate that people are taking those documents to any sort of health appointment, because it also gives the ability to keep a bit of a running record of health related appointments that someone's attended, because we don't always remember dates that we've been to the dentist or to the doctors for a vaccination or something. But it's a really good way to capture what those reasonable adjustments that somebody deserves to make their life easier.
Absolutely. And Karen, coming to accessing the services, on that note around reasonable adjustments, or what can a person with disabilities expect in terms of accessing the services?
That's a really interesting question, because I said there is no right or wrong answer to that one, because it is so sometimes dependent on the area, the surgeries, sometimes the PCNs, so the primary care networks. Some of the primary care networks are very good and very inclusive and will do lots of the reasonable adjustments outside of the GP surgery. And I'd like to say that the experience of the lady that you just shared was unusual, but unfortunately it's not. And we always say, I would like to be out of a job. I would like for me not to be needed to constantly challenge pathways and processes and people, so that our learning disability population actually is seen as included in everything. And it's really difficult. But I think from a reasonable adjustment, you can ask for, and reasonable is a very subjective word, but actually things like having a longer time, so having not more than, some of the appointments are 5 minutes at the GP surgery, for example. You can ask for a longer time so that there is time to actually have those conversations and understanding. You can ask for reasonable adjustments in the way of having the first appointment of the day or the last appointment of the day. If you've got somebody, certainly our autistic population might really struggle if it's particularly busy in the middle of the day. We always used to try and advocate a side room or somewhere quieter. Not all GP surgeries have that, but we have had people seen in cars before, because it's somebody might stay in the car where it's calm and it's quiet. And they're more comfortable, and then go straight into the GP appointment, or that healthcare professional may be able to come out to the car and have a conversation that way. I think it's just about thinking outside of the box, really, and looking at that person's needs. Is some of it possible over the phone, so that you're reducing the amount of time in the surgery, if that is what that person needs? So it's really looking at individual needs, but they're reasonable adjustments, as Simone said, under the Equality Act. As healthcare professionals, we are expected to make adjustments so that our service is accessible, and I think that's what people need to do. And I'm sure parents of SEN children or any children with any disability or health condition know that they have to fight. And that's not something we would ever say that you should have to do, but I'm sure every parent has had to stand up and challenge healthcare professionals and say, no, this is not correct, this is not right, this is what my son, daughter, sibling needs. And unfortunately, we still have to do that. But I think the expectation is that if we can educate parents, carers and paid carers on what they are entitled to, they are going to be more likely to ask for it, and push that boundary a little bit more. And the more people that ask, the more likely it is that those changes will become a bit more permanent.
Absolutely. And I think on that note, again, having services in a location that a person cannot afford to get to can also be an added barrier. One example that springs to mind is, say, physiotherapy, for example. They do a brilliant job, but sometimes they're scattered so far away into remote parts of the town, into holes in parks or what have you, with no direct bus routes either, which some residents, especially those with added needs, would find incredibly difficult in getting to. And what has happened more locally, more recently, is that there are physiotherapy sessions available at the doctor's surgery as well, which makes it much easier for residents to be able to access. And then again, I guess having an understanding of each individual's needs. Remember somebody during COVID with autism being asked to wear a mask when clearly they felt incredibly uncomfortable wearing a mask, and that they needed a carer to be able to communicate to the health worker for them, or rather than them actually having the confidence to be able to do that. So again, for the health professionals to not only accept another person attending an appointment with somebody with added needs, but also respecting them for perhaps speaking on behalf of the person with added needs. Because if they've got issues and they've got a brother, sister, parent, partner, whoever with them, and they are talking on their behalf, sometimes the health professionals are very understanding. On other occasions, they say, no, actually, you're not the patient. I want to speak to the patient. And that's where I think the transparency needs to be based on the individual's needs, and for them to know the fact that actually there's only so much they feel comfortable in saying themselves, especially when it's something that's causing them a problem and they might feel embarrassed about it and they don't really want to say too much.
Yeah.
So it's just really respecting their presence there. And if they're seeing a specialist nurse like Karen, that might not be too much of a problem. But if they're going to someone like Simone, who's an excellent practitioner, can they expect a similar kind of treatment from somebody like yourself, Simone?
Absolutely. Yeah. I mean, I think, Karen's hit the really key things on accessibility and stuff. But yeah, it all goes back to the fact that it doesn't matter what sort of a healthcare professional you are, you should be offering the same fair and equitable service to everybody. So yes, I would like to think that, yeah, you can expect the same level of service from whoever you are seeing. It goes back to us trying to impart knowledge and learning disability awareness to all the healthcare professionals that are out there, and we definitely as a team try and do that locally. But yeah, ultimately that's about breaking health inequalities down, isn't it? Health inequalities, trying to reduce them, is making sure that somebody's getting the same level of service whoever they're seen by.
Absolutely. So, Simone, going back to the Daniel review, the fourth theme that emerged from this in-depth engagement work with the local residents was around representation, the need for residents to feel represented in the services they use, was considered a critical part of those services, truly serving all residents. How is that the case in and around Luton and surrounding areas at the moment? Do you feel as though there is a greater representation in the workforce?
I think East London Foundation Trust, ELFT, has a very, very diverse workforce, not only within our local sort of our team, but within many, many of the other teams out there. In terms of recruiting, we certainly recruit a diverse workforce as well. So all of that is really good as to giving our staff workforce a good lot of knowledge about different communities out there. But I think the Denny report picked up on the problem being that decisions were made kind of without the voices of those who were most impacted on by a lot of what was happening. So I think, it's a question that we ask ourselves as a team all the time. What can we do? How can we further break down those barriers? And for us, we've tried to do a lot of outreach work, if you want to call it that, by working with local community leaders, faith groups. Karen and I have attended the Council of Faiths meeting in Luton. And I think for us, that's a really good way of highlighting what we as a service do, but equally understanding some of the barriers that people are facing in engaging with healthcare. So we can think, okay, what can we do? How can we spread the word and make sure that families of people who've got a learning disability know that teams like us are out there, know what our wider service does. So we're really keen on improving the relationships that we've got. So we've got Luton Council of Faith, there's also one in Bedford as well. So we want to be working more closely with them and other community organisations. I can speak, for Bedford, we have a Queen's Park Community Organisation. We've got the British Pakistani Society. So we're trying to sort of do little ad hoc pieces of work with them, very much taking it at their pace, because we know that, we can't go in and start dictating. We people have to get to know us and what we understand, and then it's all about developing trust in relationships with people. And so, they will feel better placed to be able to come and talk to us. I think as well, more strategically, so maybe outside of just our team, but within BLMK as well, there are lots of steering groups that happen, advisory panels, and they've got to be reflective of people within local communities as well. We want to be ensuring that anyone with a learning disability who might also be from an ethnic minority background are there, their voices can be heard when policies and new systems and processes are being developed as well. That's just kind of a snapshot of what we've done locally, but I think we acknowledge that we're probably only at the start of the journey. We know that we've got a lot further to go, but it's something that, as Karen said, we're very passionate about working with people, listening to what they want, because I think quite often in healthcare, people are done to, they're not worked with, if that makes sense. And we need to be, it's all about that co-production, isn't it? We can't dictate or expect to understand what people are going through unless we're really, really listening to them and understanding the barriers that they're facing, and then we can work together to try and overcome.
Absolutely. Thank you so much, Simone, and my thanks to Karen as well for joining me in today's show. We are coming to the end of the show now. Listeners, you have been listening to Send in the Community with me, Hafiz Muhammad Umar. My guest today, was Simone Mingay, the clinical nurse manager, and also Karen Ferguson, health facilitation nurse specialist. Thank you so much for tuning in. Please do join us again next week. Wassalamu alaikum.